The boomerang has a thin wedge and a curve of approximately 90 degrees. It is made of silicone rubber, pliable and harmless. A chain is incorporated at the periphery for medico-legal purposes. The subtle peripheral lesions are much better demonstrated. Observe at the same time 1. That the acromio-humeral window is opened, and 2. The tuberosity is preeminent. The amount of filtration is adjusted from the zone where the shadow of the shoulder falls. But here, take care, since a straight beam obscures the acromio-humeral window. To open it, a 10-degree angle toward the feet must be applied. Kyphotic patients lean forward, and the boomerang would fall if we did not insert a cushion to apply pressure against the table. In addition, the angle toward the feet must be decreased. In summary, variations in the acromio-humeral window according to longitudinal angles are as follows. At left, no angulation. In the center, normal angle of 10 degrees toward the feet. And at the right, too much angulation. Now let us study a second important element of the shoulder examination, rotation of the humeral head. Here it is in the neutral position. The tuberosity is not preeminent, and there is a risk of missing lesions because the elbow is facing forward. I turn the elbow slightly in external rotation. The tuberosity, A, is nicely profiled, and the lesser tuberosity, B, lies lower in front. This is the proper routine position. If the elbow is rotated too much, the tuberosities become superimposed and hidden. On the contrary, if the elbow is in full internal rotation, the tuberosities are again superimposed in the axilla this time. The third variable is the aspect of the gleaner, which depends on the position of the trunk. The position already used showed an open gleaner as on the left. In cases of trauma, a New York surgeon, Dr. Neer, preferred a gleaner in true AP as seen on the right. To obtain this view, the trunk must turn to 60 degrees, but not the elbow, which must be repositioned. The second view for trauma is the axial of the shoulder blade. Here the boomerang helps a little, but is not always sufficient, especially with tomography. Adding a bag of saline helps, and even mixed with iodine. Laying down, the shoulder reverses backward, and thus we must increase the angles used upright to some 25 degrees normally, and about 5 degrees only for a kyphosis. Neer's view in decubitus is tricky because in turning the thorax, the shoulder does not follow and remains flat. We have to raise the whole thorax on a firm pillow and let the shoulder fall at 60 degrees. A CT scan is often preferable. Now rest for a while and forget this overdose of shoulder. You can come back to it later. For the time being, we will now discuss other uses of the boomerang. You may protect C1 and C2, but only with patients with a preeminent lower thorax. Another application is the knee in profile with a slight flexion. One may protect the lower pole of the patella and the anterior tuberosity of the tibia, too often over-penetrated. The suprapatellar region must not be filtered, as this may simulate fluid in the joint. In extension, however, it will be better to use the 5-degree boomerang or the little prism. A superficial lesion, especially with tomography, is often over-penetrated. It will greatly improve with the boomerang or the little prism, as seen here at left. On the right, there is no filter. Another example is the anterior part of the lower maxilla, too often examined as shown on the right. With the boomerang, as seen to the left, it is perfectly demonstrated and the setup is simple. Just place the filter on the shadow of the jaw. For a cephalometry, it is possible to see both the soft tissues and the bones by aligning the thickest part of the filter with facial landmarks N, A, and B.